She's also certified in mercury removal. She also attended the American College of Integrative Medicine and Dentistry, attaining her board certification as a naturopath, as well as an integrative biologic dental physician. Completed coursework through the Institute of Functional Medicine and is certified in ozone and myofunctional therapy. Okay. She has comprehensive background, her comprehensive background allows her to communicate with physicians in their own language and create collaborative, individualized treatment plans for their shared patients. It also allows her to quarterback patient care and direct patients to help them achieve full mouth and body health. Dr. Taylor is a member of the International Academy of Oral Medicine and Toxicology, the International Academy of Biologic Dental Medicine, or Dentistry and Medicine, the Holistic Dental Association, and the International Association for Orthodontics. Please welcome to the stage, Dr. Taylor.
Welcome, everyone. So here's a disclaimer. I do not have any financial interest of a product in my talk or with any companies offering grant monies for this continuing dental and medical education program. Thanks for being here. So according to Dr. Lieberman, a professor at Harvard University who studies skulls, our faces are getting smaller. He claims that the human head is evolving faster than evolution would dictate. Our faces are becoming narrower. Our jaws are becoming retruded. In his book, The Evolution of the Human Head, he concludes the reasons for the rapid evolution is to our diets and the softer foods that we're eating. In the 1930s, Weston Price studied primitive cultures around the world that had not been introduced to more of a modern diet and lifestyle. He found that people that were not exposed to Western diets and lifestyle universally had broader faces, they were more attractive, and they had wider dental arches with beautifully aligned teeth and no tooth decay. Within one generation of the mothers being introduced to more of this, So within just one generation of the mothers being introduced to more of these more modernized foods, they started to see narrowing in the palate. The teeth started to be crooked, and they started to develop more decay. So when Weston Price looked at the different diets and compared them to all of these primitive people, he found that there were some similarities. He found that there were 4 times the mineral and water-soluble vitamins as the American diets of the 1930s. The vitamins were more readily available because they were soaking, fermenting, sprouting, and using sour leavening. There were 10 times more fat-soluble vitamins, no white sugars, no white flours, no pasteurized milk. They all did some kind of fasting, and they also didn't have the genetically modified seeds that we have today. So his conclusion was that a modernized diet encourages allergies and airway obstruction, causing mouth breathing and a change in your tongue posture, which leads to the development of a long and narrow face and malocclusion. So these conditions of altered growth are not really genetic. They are actually caused by the lack of vital nutrients during the formative period of our development. So when we're eating more of an inflammatory diet, our immune systems go into overreactive state. We see that the tonsils and the adenoids get inflamed. And this causes us to switch from nasal breathing with our tongue up in the palate to breathing with our tongue down and an open mouth. This constricts the airway. And when this happens, during the developmental period, we start to see compensation and altered growth in our children. So what is the mechanism by which all of this happens? So during facial growth and development, there is a tug of war that happens. The buccinator muscles, they push in, and the tongue pushes up in the palate. This creates a nice wide and U-shaped palate that's big enough for all 32 teeth. However, when we switch to mouth breathing, the palate is no longer supported by the tongue. The buccinator muscles push in, and they run the show. This causes the palate to collapse and become high and narrow. So when we become a mouth breather, several things start to happen. Our body starts to compensate. The jaw drops down and back. We develop forward head posture, and our muscles have to compensate for this. We also have a compensation in our airway. The spinal alignment is affected. The neck and back pain can start to come up. We develop TMJ issues, headaches, high narrow palates. So mouth breathing and airway symptoms are basically the same as your TMJ symptoms. And I don't have time to show this video, but this is an amazing video that I show to patients, and I would encourage you all to watch it. It shows how breathing is so important in their sleep. So nasal breathing is really a fundamental key piece to this development of our faces. Air over the nose stimulates downward growth of the palate. Nitric oxide is produced when nasal breathing happens, which helps dilate our blood vessels, reduces hypertension, and allows our bodies to get into that more parasympathetic nervous system mode. When we have air that's going through the nose, it's filtered, and it's humidified, and it doesn't cause drying and inflammation in the adenoids and the tonsils. It also has been linked to reduced in caries risk. So this was a really important and very interesting study done with monkeys, where they actually plugged the monkeys' noses with cones, and they forced them to mouth breathe. They studied the monkeys for several years, and they found that all of the monkeys developed an increase in face height, steep mandibular plane, and larger gonal angles. And they all had different appearances in their face and occlusion compared to the controls. They found that the nasal breathing was the trigger, but it was actually the muscles that were causing the dysfunction. So when the mouth is constantly open and the facial muscles are developing, they adapt to the function, the improper function, and the abnormal posture. So children who are developing have essentially developed muscle patterning habits around an inability to breathe through their noses. So basic human functions such as forming words, chewing, swallowing, drinking liquids, and even swallowing their own saliva are all compromised by their inability to breathe through their nose. We start to see that the face gets long, and we start to see crowding. We start to see forward head posture, just like that slide before that showed compensation. We go from these beautiful nose-breathing profiles to this mouth-breathing look. And this is a really interesting case. So the case, this kid on the left, he's 10, and he, shortly after this photo was taken, got a gerbil. And that gerbil lived in his room, and he was allergic to that gerbil. And what happened is he switched from being a nasal breather into a mouth breather, and look what happened to his face. This is him just 7 years later. You can see how it's changed his face completely, and you can see that on the left side, his development was pretty much on track. So who knew that a gerbil could be that devastating? So which smile would you rather have? Remember, a properly functioning mouth is a pretty mouth. Achieving proper growth and function will help achieve us to form to our full genetic potential. We have to treat the dysfunction for long-term stability and health benefits. Which airway would you rather have? The tongue, if it's working properly, should support and protect the airway. It should keep it open, especially during sleep. But when our tongue is weak, our jaw falls back. The tongue goes back, and this causes sleep disorder breathing and sleep apnea. We are basically suffocating in our sleep. And sleep apnea is a cycle. You fall asleep, you stop breathing, or your breathing is impaired. And then your body goes, oh my God, I don't have enough oxygen, there's too much carbon dioxide, I need to get more oxygen into the tissues. It causes us to have an arousal. And most people don't even know that this is happening when they're sleeping. And so they have an arousal, and then they drift back to sleep, and it happens over and over and over. So we are never getting fully into that deep sleep that our bodies need. And our bodies need good sleep. We need it for our immune system. We need it for learning and memory, brain function. Our growth hormones are secreted during our sleep. We need it for detoxing. We need it for psychological well-being, heart rate, and blood pressure. So I always teach my patients oxygen is the most important nutrient that you can put into your body. It's more important than any food, any supplement, even water. You can only last a couple of minutes without oxygen. It's important to every single cell. If you don't have oxygen, your cells cannot go through the Krebs cycle and make the ATP that are needed to run the body. A lack of oxygen increases oxidative stress and promotes systemic inflammation and causes our bodies to get stuck in the sympathetic nervous system stress response mode. And this has a big impact also on our cardiovascular system. So when you have CO2, which is a waste product that builds up in the blood and the brain detects it, it sends a message to the heart that says, hey, we are not getting enough oxygen here. Could you please work a little bit harder? And the heart responds by going, geez, okay, yes, I'll work harder. So it starts pumping faster. It constricts the arteries to shove the oxygen into the tissues. It goes into a complete overdrive mode, and it never allows the cardiovascular system a break to reset. So I'm not going to talk a lot about the comorbidities with OSA and sleep apnea, but this slide just shows you it's linked to all of the organs, which makes sense because all of our cells need oxygen. The CPAP right now is considered the gold standard of treatment. And the problem with CPAP is that it works really good if patients wear it. But a lot of studies show that patients do not wear CPAP machines. So most patients consider a successful CPAP wearer wears a CPAP 4.46 hours per night, 64% of the nights, which adds up to only 36% of total sleep time. So the concept of sleep apnea being treated with a CPAP and being the gold standard is really no longer valid. So how does this impact our kids? Well, more than 50% of our 4-year-olds today are breathing through their mouths most of the time. 75% of our kids need orthodontic intervention. So let's look at the developmental timeline. Most facial development happens between the ages of 2 and 5 years old. The tongue is adult size by age 8. The maxilla is about adult size by age 8 with a little bit more growth until about 12. And then the mandible shows steady growth until 8 to 10. Then puberty happens, and in especially boys, you'll see some continued growth into their 20s. So when our kids are mouth breathing and we do nothing about it, we are setting them up to have increased nasal resistance, airway collapse, and sleep apnea. We're setting them up for failure. This not only puts them at risk for the comorbidities that go along with sleep apnea and breathing issues, but it also affects the way that they grow and the way that their faces will look. We start to see their faces change from this more broad face with a well-developed jaw and airway into a face that is narrow, a setback jaw, and poor definition in the cheekbones. 15% of our kids today have sleep apnea, and most of those cases are undiagnosed. And besides the facial growth issues, kids with sleep apnea are affected just like adults. They have heart problems, depression, diabetes, the lack of ability to focus, behavioral issues, difficulty thriving socially and academically. They have daytime sleepiness. Their growth can be stunted because growth hormone is secreted at nighttime. It's estimated that 31 million Americans have sleep apnea and only 3.1 million are diagnosed. 310,000 of those are actually being treated. This means that only 1% of people that have sleep apnea in this country are actually being treated. And this doesn't even take into account all of the other breathing disorders like upper airway resistance. So I guarantee that this affects children and adults that many of you know. There's a major breakdown in educating our doctors. Medical doctors and pediatricians only get 2 hours of schooling on airway medicine. Naturopaths, functional medicine doctors, chiropractors, osteopaths, very little education. And the pediatricians, they also have no education in this. They don't recommend tonsils and adenoids be removed because kids will grow into them. They don't screen for airway issues and snoring. They don't evaluate for inflammatory diets. They misdiagnose a lot of sleep issues as behavioral issues and ADHD. So the US has seen an increase, a 42% increase in ADHD over the past 8 years. Misdiagnosis of ADHD is super common among kids that have airway issues. They have the same exact symptoms: irritability, acting out, lack of focus, easily distracted, forgetfulness, being impulsive, disorganized. So we're completely missing. We're not even running sleep studies on these kids. We're just giving them meds. And the ENTs don't understand the impact that breathing has on facial growth and development. They often don't recommend removing tonsils and adenoids or releasing tongue and lip ties. And even when there's snoring or obstruction present, I can't tell you how many ENTs I have gone to battle with and said, no, you have got to look at those tonsils, get them out of there. To remove a tonsil, the ENT wants to see that child very sick, and sick for a long time before they want to do anything about it. By the time they actually get treatment, it's usually too late. So removing tonsils alone actually has a very surprising success rate at treating sleep apnea. A lot of ENTs, however, don't go off of this, and they do the wait and see method, which is detrimental to growth. So what about the food? I go to a lot of airway classes, and they're always talking about tonsils and adenoids and taking them out, and I'm always sitting there as like a holistic dentist going, but what about the food? So there's several studies that link large tonsils and upper airway obstruction to food allergies and recommend early prevention by eliminating inflammatory foods. Half of kids that have IgG to foods also have enlarged adenoids. So identifying and removing the allergies is key to preventing the enlargement and the infections that can come from that. So milk, eggs, gluten, those are all at the top of the list. And dentists, we have got to be better at this. Only 75% of dental schools have any education in sleep apnea, especially in how it relates to kids. We don't understand the urgency of treating early and the impact early intervention can have. We don't know how important it is to breathe through your nose and how to properly screen for airway issues. And most dentists that are treating airway are making mandibular advancement appliances. They only treat adults. And mandibular advancement appliances are they're still a Band-Aid. They're not actually treating the root causes to why we have airway issues in the first place. And a lot of us are making night guards, which studies show can make sleep apnea even worse. So this is Belle. Belle has been seen by a pediatric dentist religiously every 6 months since she was a year old. The dentist who saw her never recommended that she have any kind of orthodontic intervention. They told her, yeah, at some point, she'll probably need braces, but we should let more of the teeth come in, and then we'll just kind of see what happens. So what is going to happen to this girl if we don't have any kind of intervention? Will she need to have premolars removed and retractive orthodontics? Will she need to have headgear? Will she have teeth that are impacted? And will she need to have more extensive orthodontic treatment done? Will she have problems in school? Will she develop a long and narrow face? Will this affect her confidence? We are setting this girl up for failure if we do not treat her. Traditional orthodontics recommends that children start treatment when most of the adult teeth have erupted. Braces do not solely address the underlying dysfunction and cause of the underdevelopment. By this time, it's kind of too late. Remember, most facial growth and development happens between ages of 2 and 5. Orthodontists are taught that the teeth position and the palate development doesn't affect the airway. And they're not really addressing the proper function. And many times, orthodontic treatment can make airway issues and TMJ issues worse. Another excellent video to show your patients. So, as dentists, how do we screen and what do we look for? It can be kind of overwhelming. So first we need to know what proper development actually is. So we need enough room in the mouth for 32 teeth. We want a nice straight profile. We want the palatal width to be 38 to 42-ish millimeters. Again, I just want it to be wide enough to make sure all of the teeth can be in the mouth. It should be U-shaped because that's the shape of the tongue. And there should be, like I said, room in the mouth for 32 teeth. We take out wisdom teeth just because, and I don't know if we really need to be doing that if we start to grow these kids and get them on the right track early. So in the clinical screening, I kind of go through these questions with my patients, and a lot of these you can just see when they're sitting in the chair if they don't have a mask on. So do they have open mouth posture at rest? What about during sleep? Do they have constriction in their nose? So I have patients breathe in and out. I listen to their breathing. Do they have cracked and dry lips? Do they drool? Do they have dry mouth? Do they snore? You can ask parents. Do they have small nostrils that are up-tilted? Do they have bags under their eyes? Do they have spacing between all of their baby teeth? How about any malocclusion? Oh. What about a tongue tie? What about a lip tie? Do they have any kind of ADHD types of symptoms or are hyperactive? Do they struggle to focus in school? Do they have bedwetting at night? Many kids will have wear on their teeth because they're clenching and grinding. How are their diets? Are they on the normal developmental curve for height and weight? What do their tonsils look like? Can they breathe for 3 minutes with tape on their mouth? How's their sleep? Is there a tongue thrust present? Are there cavities on the baby teeth? Do they have a history of pacifier and bottle use? How about chronic ear infections or sinus infections? And is there any thumb or finger sucking? If you answer yes to any of these, you need to suspect that there is a potential airway issue going on. So pacifiers, bottles, and sippy cups can all push the tongue down too and off of the palate. There are several studies that show that breastfeeding reduces the risk of needing orthodontic treatment and promotes proper development. But in our country, we see less and less of this. Thumb and finger sucking habits also push the tongue down and protrudes the jaw back. And tongue ties can also be a reason that the tongue has a low posture. So when we talk about tongue ties, I know there's a lot of differing opinions on tongue ties. So I'll talk to you a little bit about my view of tongue ties. So when the tongue is tied down, we know that naturally it's going to rest in the bottom of the mouth. And we know that this can alter growth and development. We also know from studies that a short lingual frenum is linked to sleep apnea in kids. So having a tongue tie, when it's laying low in the mouth, it does cause the sphenoid to rotate, and this can also alter hormone release. And we also know that a tongue tie increases cavity risk because our tongue is our natural toothbrush. So if kids can't reach their tongue all around their mouth, they can't clean everything. The thing with tongue ties is that not all practitioners are trained to accurately diagnose them. And I have many, many patients that went to have tongue ties evaluated, or they were babies and they went to the lactation consultants and they're like, there's no tongue tie there. And they go to another one, no, there's no tongue tie, no, there's no tongue tie. I'm like, yes, there is something going on with the tongue. And it's just so hard to get sometimes it's so hard to get practitioners to even see that this is an issue. So I use Dr. Zaghi's classification of tongue tie when in practice. When I see a patient with a grade 3 or 4, I know that I probably need to do a release on them. But with a grade 2, you have to look a little bit deeper. You have to really look at the function of the tongue before you decide if a release is needed. And we do this with myofunctional therapy. Myofunctional therapy trains the lip competence, tongue posture, and swallowing by teaching physical therapy like exercises. If the patient starts with myofunctional therapy and they can't do the exercises, or there's pain in their neck, or there's strain in their jaw, then I know that the tongue is restricted. And that's when I will recommend a tongue tie release. So I'm only going to release a tongue tie release if I know that there's dysfunction. And tongue ties really get a bad rep because a lot of times you just go in and you release the tongue and then you're like, oh my gosh, it grew right back. And the problem with that is that if you never train the muscles to do the right thing, they won't know how to work. So I give my patients this example. If you, at birth, have your hands tied together and you have to go through life, you're going to open the door like this. You're going to brush your hair like this, okay? Now all of a sudden, you're, 50 or 15, and I cut that hands apart. How do you think you're going to brush your hair? Like this. You're going to open doors like this. Why? Because you haven't trained the muscles. You have to train the muscles. This is what myofunctional therapy is all about, and this is why our tongue ties fail. This is why we get relapse in our tongue ties. So find a myofunctional therapist. You will not regret it. So now we have identified a problem. So what do we do? So we really have to start coaching parents from day one. Mom's got to get that good nutrition in. I recommend Weston Price's books. We want to talk about the importance of a vaginal birth instead of a C-section, because C-sections can be really damaging to the cranial bones. It can cause everything to kind of lock up. We want to talk about the importance of breastfeeding, and we want to talk about pasteurized dairy, gluten, soy, those really inflammatory foods that mom may want to kind of keep out of her diet when she is breastfeeding. I recommend craniosacral therapy, seeing an osteopath, chiropractors early on, tummy time, and avoiding pacifiers and bottles. If there is an issue with breastfeeding, I want to send that baby right away to have a tongue tie evaluation, because most of the time, the reason why we can't breastfeed our babies is not because of the mom, it's actually because of the baby. And then you also want to avoid any carriers that could affect pelvis development. All right, so let's talk about the treatment that I do in my office. So the first step is we have to lay the foundation. We gotta figure out if they have food sensitivities. We have to do nutritional counseling. Nasal hygiene, so get those neti flows out, neti pots, get the sinuses clear. I also talk a lot about sleep hygiene. So we need to be sleeping in total darkness. We shouldn't be doing screens before bed. All of these things can affect our sleep. If I suspect more severe sleep apnea, I'll have a sleep study done. But I really love this app called SnoreLab that your patients can download. And you can actually listen, and it'll give them a score in the morning of how loud their snoring was. And I love it because they can track with if what we're doing is actually helping, especially if snoring is one of the symptoms. So nasal clearing is awesome. I also send this video out to patients. It is just a really great way to clear the nose, and a lot of times when we do nasal clearing, we can avoid the need for an ENT altogether, I have found. I've had several patients that I have sent to the ENT, early on, I just oh my gosh, you got occluded sinuses, you need to go to the ENT, and a lot of them didn't want to, and so I said, well, you can try nasal clearing. And the amazing thing is that they'll go back to the ENT after they do the nasal clearing, and then the ENT is like, you're fine, get out of my office. So always start with nasal clearing. The second is we have to treat the dysfunction. So we have to retrain the breathing. I recommend Butanka breathing, mouth tape to get us breathing through our nose, myofunctional therapy to get the tongue up and get everything functioning, ENT referral if needed for tonsils and adenoids. We got to get these kids breathing and functioning the right way. This is also when I refer to osteopaths, chiropractors, and of course I'm looking at tongue ties and lip ties. And then the third part, which is the fun part, is you catch these kids then up with growth. So if you've got a kid like this that comes in on the left, this kid cannot breathe. So we're going to run through laying the foundation, treating the dysfunction, but we got to make room in this girl's mouth to catch her up to growth. This is where expansion comes in. There are many studies that show that expansion improves nasal breathing, snoring, and sleep apnea. There is also research that shows that expansion improves bedwetting in kids. Very, very well, actually. So there are many different kinds of expanders. There is no one-size-fits-all. It's important that you as the doctor pick, diagnose, and pick out the right appliance for your patient based on their growth and what they need. There are many classes that teach expansion, and they teach that their appliance is the only appliance, and it will work for everybody, and it doesn't matter what the problem is, their appliance is the appliance. And I think that is very misleading, because you have to have many tools in your tool chest. Not every kid needs growth the same way. So we need to be the doctor, we need to know the appliances, and we need to pick the one that's the best for the patient and their lifestyle. So let's go back to Belle. We laid the foundation by figuring out her trigger foods and cutting them out. This was gluten and dairy for her. We got her nose clear by her using neti flow rinses 2 times a day and using X-Clear nasal spray. Then we treated her dysfunction. So we got her nasal breathing again, mouth taping at nighttime, corrected her tongue position with myofunctional therapy, and then we expanded her. So now she has room for all of her teeth. I think those laterals are going to appreciate the nice space that they have to come into. So we have to remember that dysfunction in babies and kids is going to lead to dysfunction in adults. It just is. The longer there is dysfunction, the longer it takes to unwind and undo. So we have to recognize these things early. The 4 pillars to proper function that I teach in my office, and I tell this to every single new patient when they come in. When you leave my office, I want your tongue suctioned up. I want your lips together. I want your teeth slightly apart, and I want you breathing through your nose. And your homework for the next week is to pay attention to this. And I want you to tell me next time I see you how well you did. And you'd be surprised at how many people come back and say, oh my gosh, I never do that. Yeah, I know. So let's look at Cole. Cole is 4 years old. He looks like a pretty normal, cute kid. But let's look a little bit deeper. Cole is a chronic mouth breather. He cannot keep his lips together. They're constantly open. They have no strength. He's got a nice, cute little baby teeth smile, but I don't see any spaces. He's got bedwetting, enlarged tonsils and adenoids. He has an underlying dairy and egg and gluten allergy. This kid, we need to treat now. So let's look at his radiology report. Narrow airway, enlarged tonsils and adenoids, sinuses completely occluded. He's got reduction in the airway space, high risk for sleep disordered breathing. We got to treat this kid. So you can do this in adults, but adults are trickier, they take more time, and they are a lot more complicated and complex. So this patient here came into me for snoring. He was single, ready to get back into the dating world. He had a history of hypertension, and he was diagnosed actually with that hypertension in his early 20s and was on medication for it. So we did the same thing that we did with Bell. We identified and cut out his inflammatory foods, gluten and dairy again, shocking. Started retrained nasal breathing and mouth tape, and did some myofunctional therapy. We expanded him. He had a posterior crossbite, and boom, no snoring. Oh, we also did night lays on him. Boom, no snoring. This is a really good thing because he is actually now my husband, and I get to sleep next to him every night. So it's a win. He's also now off of all of his hypertension medications, and he doesn't have the rash that he had his entire childhood on his face that we have attributed to dairy. Another win. So why did no doctor tell him that he had a dairy allergy and an airway issue? Like, we have to help these people put the pieces together because I'm telling you, the medical community is not. He's healthier now than he has ever been in his life. This woman suffered from severe sleep apnea, chronic neck and shoulder pain, and had 4 bicuspids removed. She could not use a CPAP, and she was miserable. After treatment now, she's feeling better, she's loving her new profile, and her wider smile. So it's not impossible to treat adults, but they are way more complicated. You have perio issues, you have implants placed, you've got all of this dysfunction that's been happening for years, so it's a lot harder to unwind and peel back the onion. So we as dentists need to start changing our lens. Dentists, you should be screening your patients. Hygienists, you too. Dental assistants, you as well. Front office, start screening. People come in, they're like, I'm here for my appointment. You're like, yeah, you have an airway issue. My husband screens people when we're out, having dinner. It's so hard to unsee this stuff once you see it. And the other medical professionals are not doing this. There are so many clinical red flags that we see and can notice if we know what to look for. This is totally our territory. Let's look at another girl. She came in to me after 2 orthodontists told her to do nothing. They said, you should just let the teeth come in, and then we'll do jaw surgery when you're a little bit older. This girl is exhausted. She cannot breathe. Her head is forward. She has neck and back pain. She grinds her teeth at night. Her cranial bones are completely locked, being in this severe underbite. So, we went through our treatment flow with her. We laid the foundation. We treated the dysfunction, catched her up on her growth. We put buildups on her teeth to help push those teeth forward and unlock the cranial bones. So the photo on the right is just a couple of months after she started treatment in our office. And look at the difference in her face. She's now a happy kid. She's breathing better, she's sleeping better, her posture improved immediately. This is big life-changing stuff. So I want to talk about mouth tape because it's really scary. Nobody likes to tape their mouth. It's creepy, right? So I would say mouth tape is one of my biggest party tricks. This lady came in to me and she had a mandibular advancement appliance that a dentist had made her, and she brought in her sleep study to me to show me that she still had sleep apnea when she was wearing it. And she said, I don't know, they saying I might have to go on a CPAP, but I don't really want to, but I really hate this appliance, but I don't want the CPAP, and what can you do for me? So I started looking, and I started digging a little deeper. And I concluded that she was a chronic mouth breather, but her mouth breathing was a habit. It wasn't that she had an obstruction in her nose. She could breathe through her mouth. So I asked her to do a sleep study, and I challenged her, and I said, what I want you to do is I want you to sleep one night with your mandibular advancement appliance in, and I want you to sleep another night with no appliance and just mouth tape. She was like, what? And I'm like, yes, tape your mouth shut. So a lot of people will ask you that. That's why I give articles out to people, like, no, it's a thing, read it. It was on Shark Tank, you know? So when she came back, her sleep apnea with just mouth tape on was, her AHI was 6.4. And with her appliance in, it was over 9. She was pretty shocked because she was like, how come I spent thousands of dollars on this mandibular advancement appliance and nobody told me that I just needed to breathe through my nose? So I would challenge all of you who are making mandibular advancement appliances, please, 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 talk to your patients about nasal breathing. It's super important. And I know that it's good to get the production from a mandibular advancement appliance, but honestly, nasal breathing trumps all. So this is another case. The kid came in to my office, and you could hear him breathing down the hall. He was constantly clearing his throat. I'm like, what is going on in the other room? When I saw him, this is what his lips looked like, dry and cracked. He was only breathing through his mouth. He was like panting in my dental chair. He had an up-tilted nose, small nostrils, large tonsils, and adenoids. In his case, I needed that ENT referral. And he had 6 millimeters of overjet and was very class 2. This kid cannot breathe, and we have got to treat him. So dentists are the quarterback. I do not expect all of you to become these like airway dentists that dedicate their practices to treating only airway issues. I have, because it's my passion, but I don't expect everybody to do that. But I do want to remind you that you as dentists are the quarterbacks. These patients are not going to get this information from anybody else, and we can help people put the puzzle pieces together in their health. So we need to make appropriate referrals. We need to know when we need to make referrals. We need to develop a relationship with a sleep doctor, or even better, get a sleep test in your office so you can screen people. Recommend the Snore Lab app. It's awesome. Find a myofunctional therapist to help retrain the tongue. Butanko breathing, establishing nasal breathing. Always recommend mouth tape. It's a game changer. Nutritional counseling. And then, of course, we need to expand. You can do that expansion yourself, or find an orthodontist who's down to do expansion and understands the importance of early intervention. Osteopaths, chiropractors, naturopaths, functional medicine doctors. Find all these people that can get on board and on your team. And find a good ENT. ENTs are really hard to find, but there is an ENT in LA, Dr. Zaghi, who trains ENTs in myofunctional therapy, and he is an excellent resource. So I have an ENT that's trained by him in my area, and I only send to that ENT. Patients are like, do I have to drive that far? And I'm like, yes. And I will not treat them if they do not see that ENT. So this is a multidisciplinary approach. You gotta establish your team. Every patient is different, and the treatment is not one size fits all. Straight teeth are nice to look at, but they are not everything. Remember that in nature, proper form always follows proper function. It always falls back to the function. Long-term stability equals muscle stability. So we spend so much time as dentists looking at the mouth, the teeth, the tongue, but we forget what's behind the airway. What's behind the airway is the spine. Research shows that airway volume increases after upper cervical adjustments. So we need to be thinking, okay, let's treat our part, but we probably need to be sending them to have the spine evaluated too, because that's going to make our treatment more successful. So again, it's our job to oversee and direct patients as to where they need to go. because they're not getting it anywhere else. So this kid, for example, came into me. He had horrible crowding, can't breathe. Look at his head. I take this picture on every patient because I want to see their upper cervical spine, what it's doing. This kid needs a chiropractor or an osteopath. So I referred him to do that. Before I started expanding him, I wanted to make sure that he had a good, solid foundation before we started treatment. And again, we're going to go through our list. We're going to do nasal clearing. We are going to do myofunctional therapy. We're going to do mouth taping. And of course, I expand him. And how, everyone's like, well, when do you know when you're done expanding? Well, I know I'm done expanding when there's room for all of his teeth. I had to expand him to 43 millimeters wide, which is a very wide palate. And I'm not done with him. He's still in a lower expander, so I didn't have after photos to show you, but his smile and his facial profile are beautiful. We have completely set this kid up for success. And I do want to touch on MyoBrace because so many people ask me about MyoBrace. I love MyoBrace or any of those different programs that are stimulated by the tongue. I love the concept of them. They're awesome. I love it because it's all muscle-driven. And MyoBrace works really well in some cases, but only if it's worn and compliance is 100%. This kid here, he had 6 millimeters of overjet, class 2, and this is 3 years of treatment in a MyoBrace. He did not look like this in a year and a half. That's what they always tell you, like, oh, it takes a year and a half. No, it doesn't. It takes longer. So it can be done, but compliance has to be great. Here's another one of my MyoBrace cases. So again, several years of treatment with the MyoBrace, but look at that big, beautiful, wide smile. So we need to change how we see airway issues, and understand the importance of early intervention. Improper jaw development is 100% preventable. Many times, the orthodontic treatments can be avoided altogether. This is not a one-size-fits-all treatment, but it is rooted in the philosophy of establishing proper function of the muscles, cranial bones, spine, and jaw. By recognizing the red flags early and treating with minimally invasive care, we can have an impact on the airway, face, and total body health that can impact our children for their whole lives. We need to change the way that we breathe and how our kids are growing and developing. It first starts with awareness. So I challenge you to start looking at your patients. Talk to them about airway health. Start finding like-minded professionals who can be on your team and who can support you. If we all work together, we can greatly impact the health of the generations to come. If we all work together, we can change the normal and greatly impact the health of the generations to come. So now I want everyone to take a moment and just breathe. Thank you.